Yes, sir.
Are you ready, ma? Go ahead, ma, with your presentation.
Good evening, sir. So the topic for my presentation is a 54-year-old emphysematous patient who is posted for lung volume reduction surgery. So coming to the history, I'll first ask for history of cough with expectoration, the duration of the complaints, the amount of sputum, characteristic of the sputum, color and odor, and history of any fever or dyspnea. Dyspnea, I'll grade it according to either MMRC grading or the NIHA classification. Any symptoms of loss of weight or loss of appetite, any evening rise in temperature with chills, history of any right heart failure such as pedal edema, reduced urine output, or right upper quadrant pain, history of any arrhythmias like palpitations or syncope, and history of any left heart failure like orthopnea and PND. Coming to the past history, I'll ask for history of smoking in terms of pack years, which is nothing but the number of cigarettes per day multiplied by the number of years. History of any acute exacerbations of in the past. Any previous significant ICU stay, use of supplemental oxygen, NIV, or mechanical ventilation in the past. Coming to the treatment history, I'll ask for current medications, which includes bronchodilators, steroids, or any home oxygen that is required. Coming to the examination of such patients, general examination, I look for the body habitus, pallor, cyanosis, clubbing, lymphadenopathy, or edema. Inspection wise, specific to COPD patients, I look for the shape of the chest, any use of accessory muscles for respiration, flaring of nostrils, or any elevations in the JVP. Coming to palpation, I'll confirm the inspectory findings. Palpation wise, chest movement is palpated, bilateral vocal fremitus is looked for, and presence of any thrills is palpated. Percussion wise, COPD patients might have hyperresonant notes on percussion. Auscultation wise, I'll look for wheeze or crepitations. Coming to the investigations pertaining to such patients, other than routine standard investigations for any surgery, specifically I'll ask for chest X-ray, ECG, and echo. And coming to assessment of respiratory functions, I'll start with bedside PFTs. Some of the commonly done bedside PFTs are the cough test, where the patient is asked to take a deep inspiration and cough once. If this is followed by recurrent coughing, it is a sign that the patient has bronchitis. Then the wheeze test, wherein the patient is asked to take 5 deep inspirations or expirations, and then the patient is auscultated between the shoulder blades for any presence of wheeze. The third one is a forced expiratory test, where the bell of the stethoscope is placed over the suprasternal notch, and the patient is asked to take a deep inspiration and expire as fast as possible. When the patient starts expiring, a stopwatch is started. A forced expiration test more than 6 seconds indicates that there is severe expiratory airflow obstructions. 3 trials of such tests are taken and the results are averaged. The fourth test is a subressus breath holding time, where the patient is asked to take a deep inspiration and to hold the breath. A normal breath holding time is more than or equal to 40 seconds. 20 to 30 seconds of breath holding time indicates a compromised cardiopulmonary reserve, and less than 20 seconds indicates a very poor reserve. Next comes the Snyder's match test. This is to measure the maximum breathing capacity. We take a lighted match and we ask the patient to blow out the lighted match without pursuing the lips. If the patient is able to blow the match approximately 22 centimeters from the mouth, this puts the maximum breathing capacity at more than 150 liters per minute. And if this is less than or equal to 15 centimeters, this puts the maximum breathing capacity at less than 50 liters per minute. This test is contraindicated in patients who require supplemental oxygen. Next is a single breath count test, whereby the patient is asked to take a maximum inspiration and then count numbers. Normal patients can count up to more than 50 numbers. If it is less than or equal to 15, this indicates that there is a severe impairment of the vital capacity. Next, coming to the assessment of respiratory function, this can be divided into tests that assess the respiratory mechanics, that which assesses the lung parenchymal function, and that which assesses the cardiopulmonary interaction. Coming to the respiratory mechanics, a spirometry can be done, which can give us information regarding the forced FEV1, FVC, which is usually reduced in patients with COPD. Maximum voluntary ventilation and residual volume to total lung capacity ratio. That this is also asked for. but the single most important test which is necessary to predict the post-thoracotomy respiratory complication is something called a predictive post-operative FEV1 percentage, which is calculated using the pre-operative FEV1 percentage and multiplied it by 1 minus the functional lung tissue that is planned to be removed divided by 100. So if this predictive post-operative FEV1 percentage is more than or equal to 40%, this puts the patient at a low risk for post-operative pulmonary complications. If it's less than 40%, the patient is at some risk, and any value less than or equal to 30% puts the patient at a high risk for post-operative thoracotomy complications. Lung parenchymal function can be assessed by ABG and a diffusion lung capacity of carbon monoxide. In the ABG, any PaO2 less than 60 millimeters of mercury or a PaCO2 more than 45 millimeters of mercury puts the patient at an increased risk of post-operative complications. The DCLO is also a very important test. Any DCLO percentage less than 40% puts the patient at increased risk for complications. Coming to cardiopulmonary interaction, this is mainly done to test the exercise capacity of such patients. This can be done as metabolic equivalence, whereby anything more than or equal to 4 METs is acceptable. This can also be done using a 6-minute walk test, which assesses the VO2 max. If the patient is able to walk 6 minutes without any dyspnea, this puts the VO2 max at more than 15 ml per kg per minute, which is acceptable value. Next is the shuttle walking test, where the patient walks at fixed and gradually increased rate between 2 markers, which are set 10 meters apart. If this shuttle walking test is less than 250 meters, this puts the VO2 max at less than 10 ml per kg per minute. The last test would be to do a ventilation perfusion scintigraphy. This is also known as this can be summarized as a 3-legged stool for testing the post-thoracotomy respiratory assessment, whereby the respiratory mechanical function, lung parenchymal function, cardiopulmonary interactions are together looked for. To assess the risk of the scheduled surgery, we can proceed by asking the functional status of the patients. If a patient has more than or equal to 2 METs, then we can proceed with a spirometry. If the spirometry and the DLCO are more than 60%, then we can proceed with the surgery without any huge anticipated risk. If either the spirometry or the DLCO value are between 60 to 30%, then we ask them to do a simple exercise testing, which can either be a 6-minute walk test. If they're able to walk more than 400 meters, then again we can proceed. If they're able to walk only less than 400 meters, we can proceed with the cardiopulmonary exercise testing. If there the VO2 max is more than or equal to 10 ml per kg per minute, we can classify them as slightly increased risk for surgery and take them up. If either the FEV1 or DLCO is less than 30% and the cardiopulmonary exercise testing reveals VO2 max of less than 10 ml per kg, then we can defer them for further medical consultation and optimization, and then take them up as a high risk or consider alternative therapies for treatment. And next, coming to problems that are to be treated in COPD before taking them up for surgery is any bronchospasm which underlies an acute exacerbation. So such patients should be put on maximal bronchodilator therapy before taking them up. In case they don't respond well to bronchodilator therapy, we can give them a trial of corticosteroids. Next is to prevent any atelectasis, we can give them incentive spirometry and chest physiotherapy. To prevent any pulmonedema, these patients may be on diuretics, which may need to be continued preoperatively. Any acute infections need to be treated with antibiotics and sputum analysis, and the surgery should be deferred until the infection is cleared. The most important thing to be treated in a patient before taking them up for surgery is to ask them to stop smoking for at least 4 weeks. Stopping the smoking can reduce the irritant effect of the smoke. It can reduce the amount of carboxyhemoglobin. It can improve sputum clearance, and reduction of smoking can also deliver more oxygen to the tissues, which can improve wound healing. The last step is to adequately hydrate them, give them mucolytic therapy. Next, coming to the plan of anesthesia. lung volume reduction surgery can be done either through a thoracotomy, a median sternotomy, or through VATS, so minimally invasive surgery. The plan of anesthesia would be to go ahead with a general anesthesia with controlled ventilation and lung isolation techniques. And for analgesia, we can opt for a thoracic epidural analgesia. Following adequate NBM guidelines, when the patients can be given mild sedatives. We can place routine standard monitoring. Other than that, invasive monitoring such as invasive arterial line, central line, usually the right IJV is preferred. We should also use a fiber optic bronchoscope, and transesophageal echo may or may not be indicated based on the patient's preoperative right heart functions. Coming to induction of such patients, IV induction is usually done after securing adequate peripheral venous access using a large bore IV catheter. Usually, propofol is preferred in such patients in titrated doses because of the because such patients have they have reactive airways, so thiopentone is avoided, and titrated doses of propofol can be given. But one precaution we need to take post induction is because such COPD patients have auto PEEP, they can go in for a post induction hypotension. So this needs to be managed with preferably inotropes and not fluid, because we need to avoid fluid overload in such patients. Airway can be secured after adequate muscle relaxation using either cisatracurium or vecuronium. Histamine releasing drugs should be avoided in such patients. Maintenance of general anesthesia can be done using a mixture of sevoflurane, air, and oxygen to give adequate bronchodilation. Coming to lung isolation techniques, lung isolation can be done either using a double lumen tube, a bronchial blocker, or a single lumen tube. The most commonly done technique is that using a double lumen tube. The double lumen tube can be inserted either using a blind technique or an FOB guided technique. Usually for a left-sided double lumen tube is more commonly used than a right-sided double lumen tube. The size of the double lumen tube is chosen based on the patient's height. For males who are more than 170 centimeters, a 41 French tube is recommended. For those less than 170 centimeters, a 39 French tube is recommended. 41 French tube has an external diameter of 13.7 and a bronchial lumen diameter, internal diameter of 5.4 millimeter. And the 39 French has an external diameter of 13 millimeter and a bronchial lumen internal diameter of 4.9 millimeters. Both of them require an FOB size of more than 3.5 millimeters to introduce them. Once the double lumen tube is inserted, the position is confirmed by both auscultation and FOB guidance. And the position for this patient for surgery is going to be a lateral position. While positioning this patient, the head, neck, and the endobronchial tube are turned en bloc along with the spine, and the lines and monitors are rechecked. The tube position and adequacy of the ventilation has to be rechecked before commencing the surgery. Potential neurovascular complications include brachial plexus injury in the lateral position. This can either be compression injuries or stretch injuries. So adequate padding should be done, and the non-dependent arm should not be it should not be flexed too much, and the dependent arm should not be hyperabducted too much. Sir, should I proceed with the physiological changes in the lateral position, sir?
No, not necessary, because this itself, there is a core. You are overlapping both chronic bronchitis and emphysema.
Okay, sir.
The very beginning of the question, if you read it, it is given how do you anesthetize a patient for lung volume reduction surgery, severe emphysema.
Yes, sir.
So the COPD component of emphysema is already given as a diagnosis there.
Yes, sir.
So there is no need to mix both COPD, discuss COPD as both chronic bronchitis and emphysema components.
Okay, sir.
So here the problem is, what is the indication for lung volume reduction surgery?
One is in severe emphysema, they'll have non-functional regions of lung where gas exchange will not take place. So lung volume reduction surgery aims at removing such areas so that the functional areas can expand and create efficient gas exchange.
So they are removing the hyperinflated component of the lung. It's not only they're not functioning, it is a hyperinflated, not deflating lungs. Okay?
Yes.
And they are always a threat of exploding and becoming a bullous and
Bullous.
then becoming a tension
Tension.
pneumothorax is always there. And it also causes or increases the work of breathing because these already hyperexpanded alveoli are not of any use because they are not allowing the gas to go. It is not allowing their normal lung also to expand because of the compression.
Yes, sir.
So patients always, that is why the emphysematous patients are very thin patients who are always panting and puffing. The description is blue bloaters and pink puffers. Okay, so they are always so the work of breathing is very much more in emphysematous patients. So in order to improve their work of breathing and make them breathe comfortably, that is the purpose of this whole surgery of lung volume reduction surgery. Okay. So you need not mix both chronic bronchitis and emphysema in your description. So it requires a isolated selection of some tests only. Not all the pulmonary function tests are required. We
Okay,
need mainly FeV1 FVC ratio and the total lung capacity. That is
okay.
what we require. So I will just go ahead and show my presentation. Most of the things what you have said is all very relevant to as a general description for thoracic surgical procedures. The three-legged approach of respiratory mechanics, the diffusion function, all these things are all very relevant to any thoracic surgery procedure. But lung volume reduction surgery need not be discussed so detailed. I'll just show the presentation so that you will